All right, welcome back, everyone. If you took a break, welcome from the break. If you just joining us, welcome. This is the office hour with Innovation and Improvement Center with Emergency Medical Services for Children. And myself, Anna Goldman, and Jen Jonathan is my colleague. Will be talking about opportunities that exist with ED Expansion Project and being a proactive mentee and how to uh, having this wonderful relationship of mentorship between several entities can happen. Hopefully, some tips will help you navigate this process. And just a quick reminder, this office hour segment number 2, it is structured with you in mind. We understand it is a long office hour, so we've built some breaks for opportunities to um, get up and move and get a cup of coffee. So we are planning for this didactic part to only last anywhere from 30 to 40 minutes. With your questions in mind, we will have also an evaluation at the end where we would ask you to take your time and give us feedback. And with that, we are off to a next slide. And I will hand it off to my wonderful colleague, Jen Donathan.
Sure. So this is just covering 3 specific areas that we wanted to touch on within our work. So looking at optimizing mental health care and resources intersecting with the emergency care system. So looking at 3 distinct areas of opportunity, first being educating providers regarding community resources, so schools, primary care providers, and emergency departments. There's also supporting ED providers, again, providing recommendations, treatment, and disposition, safety planning, and then finally providing or coordinating mental health services to patients and families in the ED. So these are 3 distinct paths that we've identified for PMHCA involvement when it comes to ED expansion efforts. Again, we understand that work can look very different team to team and ED to ED that you're working with, but really pinpointing those 3 specific areas that we have been able to kind of boil down into bundles, as it were, that could be most impactful to emergency departments. So again, education and training. So again, we acknowledge that most, if not all, teams are engaged in really just provider to provider interventions. I know we've heard a few teams who are exploring maybe something that's a little bit more patient facing, but it sounds like the resounding consensus from folks is, again, provider to provider. So again, looking at this first pathway, education and training, your team may choose to engage emergency department providers by offering mental and behavioral health either training, this could be in person or online modules, or provider continuing education hours. We know that's a pretty big selling point to a lot of emergency departments. What CEs can you offer? So that's an area of opportunity that we're exploring with some teams. And these efforts are really specific to providers and really seeking to educate. What we've learned about ED providers that while in-person trainings can be beneficial or live trainings can be beneficial, it's not that they won't take it, but a lot of ED providers are very open to the asynchronous opportunities that you could provide. So again, if you can offer online modules or things that they can do in their off time, that seems to be of greater enticement to ED providers than the in-person sessions. However, if you do in-person trainings really well, do that. But consider asynchronous opportunities as well when you're considering education for the ED. You can go to the next slide.
I do want to just add real quick to that. Thank you, Jen. As Jennifer pointed out, there are different opportunities and different education hours could be provided. I also do want to recognize for all and hopefully make folks aware that providers look different in the ED, so it doesn't necessarily that you will be in contact with MD or DO. You may be as well working with nurses, social workers, if the ED has one and other staff, sometimes EDs employ um, uh, what am it's escaped me, but EMS providers. Who have different training and preparation, but who would be very instrumental in your projects and in your work. So there, the reminder is with education is to tailor your education to the providers you're working with, which may or may not be MD and doctorate degree prepared folks, but you may have nurses with advanced practice nursing and not advanced. So there are different CE and CEUs. They're called a little bit differently in each profession. So just something to put a pin in and keep in mind.
Yeah, another thing I was thinking, Anna, to add to the different providers that you mentioned, is that oftentimes in the emergency department setting, you'll find that there are unlicensed staff, so maybe medical assistants, some people call them techs, a lot of different, but they're unlicensed staff that oftentimes are the ones that are sitters for the behavioral health and mental health patients in the emergency department setting. So that's another good opportunity for education and training because they're usually the ones that are spending the most time with the patient.
That's a great point. Thank you.
Mhm.
Thank you, Gina. Yeah, yes, absolutely. When we include, make sure to include somebody and ask, who is sitting with the kids when it's most needed, and talking about safety planning and so forth, and include this type of folks, and having it actually being in the collaborative team education is probably I would think the most effective in the ED team settings, especially in the rural settings where they are very tight community of employees for that particular hospital or medical center. All right, and with that, I'll give it to Jen. A little bit
Sure.
more description on education.
Yep. So these are just examples when you're thinking about educating providers and considering resources to pull into this. So first, looking at your ED providers, considering evidence-based practices. So you might be considering educating providers on the different types of suicide screenings, what's out there, what's considered a best practice, or maybe multiple that are considered best practices. Maybe looking at suicide assessment, community mental health resources for kids who are discharged. So again, considering what happens to kiddos after the fact, educating providers on what those services can look like. They could be teleservices, intensive outpatient therapy, maybe follow-up phone calls, etc. And then also looking at the best practices again for children and families who are boarding. So again, those kiddos who are staying for prolonged periods of time in the ED because they might not necessarily have placement available for these kiddos and their families, or they might just not know what's in their area. Considering what resources do you provide those providers with regards to boarding? Also, if you're going to have kiddos in there for prolonged periods of time, the EIC does have a resource that can just help EDs consider, if kids are going to be here, and again, it can't always be prevented, how can we ensure that they are getting the best experience possible? Again, emergency departments are very stressful environments. They are not set up to be very calming places for kids, especially those going through mental and behavioral distress. So what can we do to educate providers and their staff to maybe create a more welcoming space, or maybe designate a certain area within the ED that they can put these patients if they're going to be there for a while? So, and then moving along the boxes, again, if you're working with primary care physicians or school nurses, looking at when to refer, what to expect, follow-up best practices, looking at, identifying when to send a child to the ED. We have some teams who are working with schools right now to help them really know when it is appropriate to refer to the ED. And again, there are times when it is appropriate, but a lot of times it isn't. And so helping distinguish the differences between when it is and when it isn't is crucial. Also being able to, know what to tell families regarding the ED experience. Again, emergency departments, they vary from setting to setting. However, it's helpful if you can at least help set the expectations for parents if they do get referred to the emergency department. Again, who they might interface with, what they might experience while they're there. And again, we know that we can't know everything going in there, but at least you can help manage those expectations. Educate again on screening.
Another good one, Jenna, if I might jump in here, is to talk about, it may not be always where the child is in the emergency department that has an inpatient unit. So knowing having that explanation that your child may or may not be admitted to the hospital, that may or may not be transferred to another facility. There's a lot of connecting pieces if this is something that PMHCAs are engaging with ADs, are aware or can learn. That's a huge piece for community to be aware of what this hospital in our community can or cannot do for my kid. Just to add to it. Thank you.
Mhm. Again, screening tools for ED referral, looking at how to ensure follow-up with the patient and family after an ED visit. Again, you want to make sure that we're not losing people or they're falling through the cracks. What can we do to ensure a seamless transition between places? And then also looking at how to advise families on when to send children by private vehicle versus EMS. Again, looking at that appropriateness. Um, and then again, families and teens, again, focusing on awareness, recommendations, expectations. Helping families understand the signs of mental illness in your child, what to look for, when to go to the ED with your child. Again, when is it appropriate to escalate it, or can they, wait to go see their primary care physician? Again, managing expectations, what to expect if an episode happens. Also, really just helping families to advocate for their child. Just again, knowing what to say, knowing how to navigate the system. Again, if you have families who are going through this for the first time, they don't necessarily know what to expect or maybe how to advocate for themselves. So finding those resources that you can connect them with, or with the providers with, that they can provide the families. And then again, signs of mental illness in peers and what to do. Again, just creating better awareness for families and helping pinpoint things early and being more proactive when possible. All right, you can go to the next one.
I want to just pause to see if anybody has a chat or a question. Please unmute if you do.
I do have a question. This is Jocelyn. So when you're talking about this facilitating providers community resources, so are you doing this kind of training and outreach directly to families and teens, or is this kind of this education for families and teens, like specifically, is coming kind of via the primary care physicians, the schools, and the ED providers? So, or is it both? So can you talk a little bit more about the kind of the delivery to families and teens?
Most of what we heard from teams is that a lot of this is facilitated through the providers. Again, I think there's always the concern of liability. They don't necessarily want to assume that risk if they're doing any kind of direct face-to-face with the family. I know one of our teams is providing educational resources, but then they give them to the primary care provider to disseminate through their practice.
Right. So PMHCA team, to add to Jen's thoughts there, used as a connector and maybe creator of some of the materials. And then yes, they are not directly intersecting with families, but going to the places where families are, schools, primary care offices, EDs have all waiting rooms. There are opportunities to drop information there. So that's one approach that I've heard. And I probably missed something, Jennifer, that
No, I think
that we've heard.
I think that's a great question. Again, as we've talked with teams asking if there is any kind of interface with families. Again, I think a lot of them don't want to step into the realm of what might appear to be assuming risk. So yeah, I think it's more the provider facilitated intervention.
Okay, thank you so much.
Yeah, for sure.
There's so many opportunities. Well, there's so many opportunities with this.
Yeah, I think an area that I think some folks are also exploring. So again, it depends on the level of risk in which your team is willing to take. So we've worked with a program out of North Carolina called the North Carolina Telepsychiatry Program. They're not PMHCA affiliated, though they are working to connect with their state's PMHCA. But they are a consultation only service. However, they do have providers who interface with patients. Again, that consultation is still recommendation based, and everything goes through the approval of that patient's provider. But that's one instance that I think, we've exposed PMHCAs to as a point of consideration. That again, you can still expose yourself. Like, and again, I'm not an expert on the legalities of, risk assumption, but I think we've had those kinds of conversations with PMHCA teams because I know that's a big interest from a lot on the provider side. We can educate on that side, and providers obviously are willing to interface with their patients. But I think an area of intrigue for a lot of providers is just like, well, can I put my patient in front of one of these experts? And so I think some teams are considering that. Again, how can they maybe do that without assuming that level of risk? What does that look like? But yeah, just some consideration.
And to add to Jen's comments on the education side of things, it's especially providing education to families. Usually, when we come to the hospital settings, they're actually team of one, sometimes at one, sometimes more, of administrators, and probably my colleague Dina can add to it, but who was an AED nurse manager for a long time. But there are folks who you could connect with within a hospital setting and say, we'd like to provide this education. Um, Take a look. From speaking from the legality perspective, is it something that you would be interested in? And we will update it on a regular basis. So sometimes it takes that knowing who to go to with that education. So there's a little bit of a thinking process that should go through it. Even providing the education in the lobby, there's something that we should be aware of before we bringing it at a pamphlet to share with the family. Just wanted to put that out there. Just a little bit of a consideration for legal opportunities there. All right, moving on.
So then this is what most are familiar with. Again, the teleconsultation services. Again, your team might decide that your consultation service is kind of your bread and butter, that is the thing that you will offer to ED providers. And again, consultation can look very different depending on what your team's capacity looks like. But it could be providing guidance on specific screenings for pediatric patients. It could be advising on medication management recommendations, providing guidance on discharge and safety planning, what happens to a kiddo when they leave. And then we've heard some teams hosting weekly office hours with a mental health specialist. So consultation can look different hospital to hospital. It's really assessing the needs of the ED that you're working with and seeing what's going to be most advantageous and what approach is going to give you the most reach with providers. We had a group conduct focus groups with their providers in trying to implement, I believe it was, I think, more education focused. But again, they started out with an approach and they got some feedback. And so then they tried to implement, kind of what they heard, and what the providers were saying wasn't matching with their behaviors once they started to implement. So again, I think trying to address early on and trying to manage expectations and see what's going to be the most realistic for providers. You might have one ED who absolutely loves the one-on-one consultation. Others might just be like, hey, we're too busy, but you know what, if you set up, maybe 2 office hours a week, we'll hop on and, treat it as a huddle. So there are very different ways to approach it. So don't be discouraged if, it works one way here, but it doesn't work this other way here. Every ED is different. All right. And again, so what does it look like to support ED providers in real time? So again, mentioning that, providing recommendations on mental health screening and or assessment tips. So again, covering questions around confidentiality, what are the age minimums for assent or consent, involvement of parents. That seems to be a big one for a lot of EDs. When we participated in a collaborative last year with emergency departments from across the country, there was a huge question about what is the best practice of having parents of the patient in the room versus not. Many people didn't necessarily know, what's the minimum age. So those are things to make ED providers aware of because it varies. Also, treatment recommendations and resources. Again, ED providers are really good around the acute management. They're really good at addressing some of the the physical acute problems that are happening, but a lot of them aren't necessarily aware of like, what do you do in a mental health presentation? What does it look like to address agitation in a patient? How about depression? How about suicidality? These are areas that are still kind of nebulous to a lot of ED providers, especially those out in rural communities or who don't necessarily interact with pediatric patients. A big gap we see, it's not necessarily in the children's EDs or the children's hospitals. It's those community-based practices who, are primarily targeted towards adults, but kiddos still come in through there. So how are we educating those practices around things specific to pediatrics? And then finally, outpatient resources and follow-up programs. That was a big piece of information we got from that collaborative last year, and asking EDs kind of like, what is some of the most, what is the most pressing issue or resource that you need for your kiddos? And again, we covered screenings, we covered medication management, but a lot of them are like, we really want to know what to do with these kiddos and how do we ensure that they're getting to the resources that they need? Are they getting connected to those resources out in the community? And then how are we ensuring that they don't come back? We want to make sure that they have a program that they've been connected with a primary care provider. They're connected with a mental health resource in the community because we don't want to see them back here. We want them to have help. And then looking at community services and resource navigation. So again, kind of on that discharge and safety planning note, a lot of EDs are really interested again in having assistance and getting patients connected to the resources out in their community. They might not necessarily know what's out there, or even if they do, it's hard to keep tabs on it because resources change all the time. Different places take different insurances at a time. Some might be at capacity, some might close. It's variable. So your team might want to determine if it can serve as a point of, maybe being a community resource connection for providers. Maybe you can help maintain a list of kind of what's current out in the community for these providers. Resource connection, again, can vary based on the needs of the ED you're looking to work with, but it could be providing guidance on resources to connect to patients or connect patients to out in the community. It could be utilizing different processes, telehealth platforms or other technologies or modalities to connect these patients to providers or places in your community. Or maybe even going that next step and offering telepsychiatry services to patients upon referral. So again, the NC STEP program I mentioned previously, they have licensed mental health specialists on their team who are a resource that providers can refer their patients to. And again, these referral sources, again, they act as consultation services. They are definitely not caring for the patient, but they're being referred to their patients are being referred to these providers to help assess and get extra eyes on the kiddos. So then that professional can go back to their referring provider to say, hey, we've seen XYZ in your patient. We recommend these next steps, or hey, we recommend these kinds of resources. And again, though, the burden of care is still on the provider to make that decision. So there are a lot of different ways you can slice it. But again, acknowledging the differences of each ED, really trying to pinpoint what is their greatest area of need and how can your team meet that need. And so again, looking at providing or coordinating mental health services, what could that look like? Looking at the scope of emergency mental health services. Again, looking at the disposition planning of the ED, what does it look like? Is that something that maybe you can assist with? Offering care coordination services, or maybe just working with them to identify opportunities for care coordination. Acute evaluation and treatment, follow-up after discharge, looking at short-term intensive outpatient services, and then referrals to other mental health resources. So all of these kind of fall under the umbrella of just that coordination of care. And again, it's just some points of consideration for your team to think about, hey, do we have that kind of resource on our team? Are there others that maybe we can collaborate with? Or maybe it's just getting educated on what these look like and working with ED providers to see within their own systems, how can it, any one of these be realistic in their workflows? I'll pause there. Any questions about that? There's a lot to consider. And again, it could be really overwhelming, but this is where it's really important. One, to conduct that needs assessment with the emergency department that you're looking to work with. and really trying to understand where their gaps are, what their needs are, seeing, they might express, we have a gap here or we have a problem here, but then also seeing what are they willing to do or explore with you to bridge that gap. Because again, we've seen some teams go through the process of conducting the needs assessment and they find the gap, but their ED wasn't necessarily ready to implement the potential change effort that a PMHCA was willing to bring into their setting. So kind of take all of these with a grain of salt. It's really just a bag of options. So that way you can explore together kind of what is within your capacity as a team, but then also really assessing what is the need of the ED, but also what are they willing to also do with you. All right. And again, this is just rehashing the different paths and just how we've bundled them.
These are awesome points. All right. We wanted to point out we have several teams that are a part of a quality improvement collaborative this year that is working with AMSC and AIC, Jen, myself, and Tina and Hannah and many other colleagues as to a expansion to emergency departments. They're listed on the right side. And as you see, they're all over the United States, and there's a variety, different, representing different demographics and different opportunities. So we just wanted to remind folks that these are teams that are collaborating and opportunities to connecting with those teams in the future could be vast. So as you see, we are our most western western state is Washington, and we are like have a cluster of teams from the middle of the state and um, east north Vermont we go to, in Delaware and North Carolina. So there are a majority of there are many different opportunities in connecting with teams that are involved in this work. So if you weren't aware that these teams are working with AGs, we wanted to point this out here and to speak a
A
little bit
question,
about.
I'm sorry, Anna, just a question. Those relationships that you have with those PMHCAs, are those formal relationships, or are these the relationships that kind of they form kind of organically because we begin engaging with you like this, or is this something we like contractually do with you? How do those relationships
It's a great question.
form?
Yeah. Jan, you wanted to elaborate on this? I can get us started. So we've about a year ago, as we've talked about the toolkit. We came to a number of teams, and we indicated them here as returning teams: Delaware, Michigan, Oklahoma, Tennessee, and Washington. And we've recruited them through the webinars and orientation and said, we want to do something that would help everybody in the creation of a toolkit. That's something that's helpful and educational and useful. So we've conducted several focus groups at which these teams were present that helped us construct and organize our toolkit. And that led to further discussion in creating of a collaborative community. And then this year, as you see, the new teams are tagged here, but those are the teams that joined that collaborative. And then I'll let Jen talk about the different relationships that we have with the teams. We have a plethora, so this is a menu of opportunities, but I'll let Jen to elaborate a little bit more about the collaborative.
Yeah, so again, some teams have entered into contracts with us. We do offer funding for those who want to participate in our quality improvement collaborative. We make those funds available and they'd have to go through the whole contracting process for those. However, to be a part of the quality improvement collaborative, there's no contract that we have folks sign. We contract expectations if you participate in the collaborative. It's, what we offer here, like technical assistance webinars, this is a very informal setting, and we're not really putting any expectations on teams. But for those who want to dive a little bit deeper into a structured curriculum that we've put forth this year, again, they're not signing anything, but we're saying, hey, by agreeing to participate in the collaborative, we would love if you do X, Y, Z, throughout this process to get the most bang for your buck. I hope that helps.
It does. Thank you so much.
Yeah. The way we approach our collaboratives, and again, through the EMS for Children's Innovation Improvement Center, again, quality improvement is kind of our bread and butter. And that's like, we try to do that. We try to make these learning collaboratives as a free resource to folks who, again, are interested in a particular subject area. I mentioned a collaborative earlier. We had one, again, it was around acute suicidality in the ED. And so we put forth an ask to all of the nation's children's hospitals to say, hey, we'd love for you to participate. Again, it's free to them. Again, we try to manage expectations, say if you participate, we ask you to do X, Y, Z, attend so many meetings. But again, trying to create, the lowest barrier to entry to bring as many people together in that learning environment.
In the essence of the collaborative with PMHCA this year is actually just what we talked about in the beginning is picking the project that you maybe already submitted to HRSA for a de-engagement and just seeing it through. Basically having this, I call it protected time, where you have opportunity to connect with others that are maybe engaged in the similar work and share best practices. What's working for you, what doesn't. So we have a guided discussion, collaborative opportunities every other month. And then we had a face-to-face meeting in Cleveland that provided for even more kind of that shoulder to shoulder, tell me how you do this type of collaborations and discussions. And leading to, again, as Jen mentioned, we are all about QI and having measurement. Like, how do we know that what we're doing is actually successful if we don't have baseline data? Well, where are we starting from? How do we know we're improving? That collaborative time, which we're going to have upcoming one in September, our final collaborative meeting with all the states provides for that. Even if you are just an explorer and looking to, okay, I don't know where to begin. This kind of discussion and being in an environment with other like-minded individuals who are maybe in the trenches or have uh, been in the trenches for a while or just beginning kind of helps you to identify that path. So hopefully this is helping. And then we did want to point out, if you are already kind of have a goal in mind, these are the teams that are focusing on certain work with the ED. And then as we identified several pathways earlier, and Jen pointed out the in and outs of each. We do wanted to point out that, for example, Vermont, Oklahoma, Chickasaw Nation, and Delaware are looking into education and training pathway and have been connecting with EDs. Delaware particularly also works with schools in understanding what EDs can and cannot do. For provider to provider consultation services are rising stars or stars of the show are Michigan, Washington. We also do include ANSI STEP here from North Carolina. They are very willing to, even though they are not PMHCA, they are very willing to tutor and mentor and coach and provide all kinds of documentation. If the provider consultation in the ED is your interest. And then patient community resource navigation are rising stars of Minnesota and Tennessee. There have been had programs there for a while that has been very successful. For example, I know Minnesota has reduced their boarding time by connecting EDs with um, community services that are available via it's a I call it a navigation, community navigation forum. So one program that has done wonders. And if you would like to duplicate something like this in your state, that's a program to connect with. Anything to add here, Jen?
No, I think you're good.
Okay. All right, so with that, we are on to the next part of our presentation. And hopefully you got an idea that it is a good idea to have someone you can ask questions, connect with. And so we call that relationship as a mentorship opportunity. And so why do we do it? Often we actually doing this without recognizing that we're doing this. Sometimes mentorship is mentioned as coaching, but I think mentorship has a little bit of more of a formal opportunity. And so with that, we wanted to dive in just a little bit more how this, why do it, and how we do this. So benefit of mentoring is helping to develop the goals together jointly, obtaining advice. Sometimes, as you know, advice could worth more than anything else. And getting the advice at the right time is an amazing opportunity. Also, succession planning, thinking about your team and who would want to you wanted to coach and mentor to maybe take some of the work later on. And then, believe it or not, having a mentor and being a mentee is good for a work satisfaction. It makes us happy to share our successes or our opportunities to learn, and for somebody to point it out and to say, that really didn't work, or you did a great job here. Um, and this kind of motivates us, and it gives us ideas for how do we move forward. So work satisfaction is another a great um, motivator when we have those mentorship and mentoring opportunities. And reducing burnout, believe it or not, our work is hard. Right? We do get overwhelmed with information and several things coming up at once. It's having that kind of communication, open communication with our mentors is what could be helpful. And having that dedicated person who is kind of not that they always going to get you back, but they are there for for an opportunity to ask, for an opportunity to converse. I call it a venting opportunity sometimes, just to make sure that we don't take too much time. We want it to be um, having it an organized approach. So how can that relationship look like? So I dug up, this is a somewhat formal diagram, but we do mentor people often without recognizing we're doing this. However, when we are taking this to more formal um, um, group approach, and one with the situation may arise where your PMHCA group decides to connect with one of the states that were mentioned above and say, oh, so how do we do it? How do we become proactive, and how do we prepare for this kind of relationship? To connect with another PMHCA, to connect with another TA provider, to connect with another, maybe an office or a school system. We come prepared, right? So one way to help us being prepared as a mentee and prepare the mentor to the relationship is having those goals, mutual goals in mind. So before you come to that meeting, have an idea of, do a little bit of your research, read up about the information about the team you're going to come in and join or have a meeting with, and have those goals identified. So you come in with a set of goals in mind. It could be short-term goals, or it could be long-term goals, but you have those in mind. It doesn't mean those don't get adjusted as you meet and learn more about one another, but you have done your homework, and you've prepared into that relationship with your goals in written down. You should have before even you begin this relationship with your mentor or your mentee, you should have an engagement rules. Have time, dedicated time or idea. When do you want to meet? How often do you want to meet? What the early meeting is going to look like. Are you going to have an agenda? Are you going to have a formal minutes taken? Do you want this to be in a formal format, or do you want to be informal? So there are things to think about before we engage with another stakeholder or another a group to work with. And this goes back into commitment to feedback and support. Do you want have a set of questions for each meeting set up and send them ahead of time in the form of the agenda or in the form of the questions before the meeting starts? And keeping those open line of communication. Right, so we don't go with that. Okay, we had a meeting. We haven't. We had a meeting where we had all the goals identified, and then I haven't heard from you for 2 months. Right. So what it tells me as a mentor, or what it tells it to the mentee, are we now? Do we have trust in dedicating the time um, to connect and to have this conversations going. So those are some things I wanted to mention before you reach out and um, begin this engagement. It's good to have those um, circles around the mentee development identified and kind of um, set as an outline for that meeting. So you come in and the perception of your coming into the relationship is prepared. You could tell that we have evaluated our team. We have looked at our resources, and this is where we are. This is where we're coming with. So your meetings with your mentor become much more proactive as they know what the conversation gonna look like and what you personally or your team wants to get out of it. What advice are you getting to gain? So when it comes to mentee and mentor relationship between different teams, right? That means that your team needs to sit down together and prepare those goals and outline the time that it will take to connect with another team, right? So you do that before the actual connection happens. Now, does it happen all the time? Probably not. But if you think and have time to prepare, this will be a great opportunity to sit down with your team together and think of doing a little bit of a analysis and thinking, okay, what are strengths? What do we already provide, for example, for primary care offices? What can we provide for EDs? What are opportunities? What staff do we need to still hire? Who do we need to still connect with? And then having this information delineated and kind of prepared in your minds on your plans, you then come with that relationship. You reach out, for example, to one of our team in, Tennessee or Washington and say, okay, this is what we are. This is what we're working on. We understand you are working on ED connection in connecting with ED providers. And would you be willing to sit down with us and start this conversation? And and asking them, would they be willing to have monthly meetings or whatever that relationship may look like. And then, of course, it's sitting down and creating those mutual goals. So if your vision is one and their vision is another, this may not be a good fit. So having this kind of visions and missions of that project of ED connection. For example, it could be different projects, but we are promoting your ED engagement. Crucial to having those conversations. All right, so that's a little bit about mentee and key attributes for mentorship. Other ideas, there's experience that people have had in their lives that you would like to share that where the relationship didn't go well or did. I'm sure all of us had those experiences with our teachers, friends, colleagues.
Well, I had an experience where I had a mentor in my last position and we met a couple of times. And then the third meeting, she told me she was leaving the company. So,
So that, how would you think this would have gone differently from the first meeting, from what
if she
we
would have
talked
just,
about?
if she
Mhm.
would have given me that information up front, then I probably would have looked for a different mentor. But she didn't disclose that until, I guess it makes sense, I guess, to protect yourself and not have to say that, but would have known I would have chosen someone different.
Well, and it's a good point, Hannah. It also reminds me, sometimes we feel that once that mentor is like for a long period of time, uh, the boundaries of that relationship could be one of the things that you discuss at the very first meeting and say, how let's set up the goals. And that actually, as you talk about the goals, how this relationship would look like, it would help having organized this kind of, or having this the vision and saying, okay, this is going to be 2 times we meet, and this is a short relationship where I'm going to teach you this particular issue or this particular project that we're going to work on, and that is okay. The mentor-mentee relationship could look very different, and could be used for different reasons. So exactly as you pointed out, having that ahead of time at the very first meeting would be something that both parties would enjoy, right? Having that expectations of that relationship. Very good points. Thank
That's
you.
a good point too. Thanks.
Yep.
I feel like we do this pretty well, or at least in my experience, being a previous nurse manager. When we would have, like, for myself, I was a nurse manager for 10 years, but then you would have new nurse managers that came in. And I think you would naturally like kind of do this and form those kind of dyads where you would have that open communication and find out from the person like that was going to be the mentor, me as the mentor asking the mentee, what are things as a new leader that they really want to focus on. So then we would be setting mutual goals. And then we would commit to maybe we meet weekly just to kind of check in and see how things are going. But over time, and that relationship and that person, starts to grow in their role, then maybe it's more, you know, now we're not meeting on a regular basis, but hey, today I have this issue with an employee, can you give me some guidance on how you might approach this situation? And so we might do some role playing and stuff together. So I kind of like this model here, but it's something that even without having that model there,
All right.
we already really naturally utilized it, I don't know if that's
Yes.
helpful, but we definitely had experience with doing this as a nurse manager and doing that with new nurse managers, new leaders.
Mhm. I also like, Dina, how you pointed out that the relationship has changed, right? Where
Mm-hmm.
we originally, and this will happen. And so it's good to talk about this actually in the beginning and having this kind of in mind. I understand that, in the beginning, we might be setting up meetings every 2 weeks, or, you calling me every 2 weeks, but then um, probably 6 months from now, I would think that this relationship would be on as needed basis. But this is something to kind of part of, I would call it in rules of engagement
Oh
or an
yeah,
orientation
absolutely.
process. It's good to have that kind of goal setting, and talk about this at the very, very beginning of this relationship.
Mm-hmm.
So, and I know some of organizations support that greatly. In hospital settings, but even in informal organizational settings,
Mm-hmm.
you have that opportunity. And believe it or not, we talked about what mentorship can do for you, and not only for the mentee, but then for mentor. I think I've learned so much from the mentees
Absolutely.
often, because they come with a lot of information, and especially
Mm-hmm.
if you have a student who is been in school recently, there's so many different um, opportunities for us to refresh our knowledge, right?
Mhm.
As mentors, and kind of refresh on things that are happening around. So it's a very rewarding relationship, and um, from that one-on-one perspective, it's great to have somebody like that in your organization or in your department. But then when we
Yeah,
look
I
at the
agree
bigger picture,
completely.
yeah, when we look
I
at the
agree
bigger
completely.
picture.
It is. It's
Mhm.
like that bi-directional where you really, even as the mentor, you can grow and learn. And I think it also helps you to, I think sometimes we have and I don't know if it's just from a nursing perspective or if all of you like, in the mental health and, social work world, sometimes I think it also helps to validate for yourself, like that whole emotional intelligence and really validating the skill set that you have too, as a mentor. It's kind of profound. It's kind of nice, because sometimes you need that to kind of fill your bucket. So I don't know. Just another
Yeah,
thought.
yeah, absolutely. And then from PMH, when we look at the, teams that we've identified earlier, and might be PMHCA representatives that are here today, um, so how do we do it with a team to team perspective? How do we prepare our team to engage with another team? um, Ideas could be then, all right, we like what they're doing, and this is where we are, but then come prepared to discuss that at the first time you meet and say, this is what we want out of this relationship. So because all of us, as you guys know, are pulled in thousands directions, and especially at the some of the projects that PMHCs are involved with, and how do we so help us stretch and engage, but then do it in the way where we have um, ideas and goals written down, and that helps keep the relationship cordial and understanding, and of each other time, and respectful of each other ideas and thoughts. So just a thought, it would be a great time to talk about this. And so with that, uh, just a last diagram that I wanted to share with our PMHCAs. And those are the things that Jen identified earlier, and how we are looking at some of the opportunities that exist with our communities. And this diagram kind of helps us putting it all together. But PMHCAs are a great position to be that connector, where we have mental and behavioral health of a child in the middle, and actually it's a patient-centered approach. And what are the opportunities? And they are vast, whether they're not they are with educating providers in the ED, or connecting primary care providers with the emergency department, even to understand what emergency departments do. This could be the role of PMHCAs, helping families understand, or align their knowledge, what the hospitals and emergency departments in their area do or don't do. Are there any other opportunities with crisis centers and outpatient settings that could be more proactive for the condition of this child? So those are some opportunities. Another big players are schools. Um, this is where I call a child's habitat, right? So are the school providers, the school social workers, nurses, um, do they even have a nurse in the school? There are sometimes some areas they have no nurses for one nurse for 3 to 5 schools. So how are we helping navigate school community, the rest of the services that are available in the area? Those are the great opportunities that we can help engage, and having the connection, where PMHCA could be that integral part of the community that working on this. And don't forget, the emergency departments are not just in hospitals. They're EMS providers who are the first responders and have to provide that um, care for a child they may have to transport to one or another location. So what tools or instruments do they have available, education they have available um, to do this work. And as we know, the mental health care, especially with COVID, is for our kids is something that is we called a pandemic, right? So this is not going away. So opportunities are vast. So hopefully from this office hour, you picked up on some of the teams that you can connect with, can reach out to us, and we'll connect them with you. Please reach out and have an individual consultation. We can discuss more and talk more about on how-tos and point out to some tools that we have available. I wanted to point out this reminder of the upcoming webinar on August 27th for those who have just joined us. With that, we're going to put up an evaluation poll. Please hang around for a little bit longer to complete that. And we'll take a 5-minute break. And after the poll is completed, Hannah, are we ready to launch? Please take the
Hold
time
on, real quick, hold on.
to provide the feedback. Thank you. That would be very invaluable to us. And I see Hannah put up a poll. This is segment 2 of our office hour. We will give you time to evaluate. This is a different evaluation if you were with us during the first office hour, the first segment. And I'm gonna just be quiet so folks have time to complete. So just a reminder, if you just joined this office hour, we are having a 3-segment office hour this time. Today, August 13th, and our next segment will start at 11:05. We're running a little bit behind, but we are at the end of our second segment. Please complete evaluation. You should see the poll in front of you, and it has 5 quick questions. And so once you completed the poll, we are welcome for you to take a little break. I know 2 hour could be a little bit too much to sit at the computer. So great, grab a snack and come back at 11:05. At 11:05, we will talk about selecting the appropriate interventions, how to identify the most impactful intervention for your project. We'll talk about process mapping and what is it all about, and we'll talk about root cause analysis, 5 whys method, and change management. Just a little bit about the change management and why is it so difficult sometimes to get on the same page. All right, we're going to keep the poll up for 1 more minute. Please, please, please complete it. It's a different poll from the first segment. All right, Hannah, we can stop our poll. All right, we're going to stop recording.